Okay, we got a lot of people on right now, and I think we'll just go ahead and get started. For some of you who've been here for a little bit, you've noticed that we're having some technical difficulties. And the technical difficulties is I can't share my screen, but this is not a photo-intensive talk. This is mostly just me talking, and what I had to share was just something that you could look at rather than having to look at me. So we'll go ahead and get started with this. And I'm going to begin with basically a personal timeline so we can put some perspective into this. I went to medical school starting in 1977. I was 20, graduated in 1980. This was Baylor College of Medicine in Houston. 81 through 85, did my internal medicine residency in Dallas at Southwestern. 85 through 87, did a pulmonary fellowship. In 87, I moved to Austin and joined a group of two people, Mike Shapiro, Bill Deaton, called Pulmonary Disease Associates. We were quickly nicknamed DSW for our initials. November 1991, we formed a group of 8 people called Pulmonary and Critical Care Consultants of Austin, PC3A, or the PAC. And then in 2022, our group shifted to Ascension Medical Group. This year to USACS, we now have 22 physicians, although at midnight tonight, they'll actually have 21. Somebody is sharing it. Beth, is that you sharing that?
Yes, I got it figured out.
Cool. Okay, well, how cool is that? So, okay, we got something there. Great. So there's a bunch of changes that have happened in the 48 years since I started in medicine. And, these fall into lots of buckets, things we know now that we didn't know before, drugs we can use now, things we can put in now, fancy electronic gizmos, how care is organized, who's on the team, the fundamental purposes of the chart. A lot of things fall into 2 or more categories. I'm not going to necessarily be talking about all of these, and I will leave out lots of stuff, but most of what I have is going to land into something along those lines. And we're going to start off with infectious disease because some of my earliest experiences in terms of change related to that. So just before I started medicine, July of 1976, there's a mystery outbreak of pneumonia in a group of Legionnaires attending a convention in Philadelphia. And this was actually recognized by doctors who were chatting in the doctor's dining room. This wasn't found by a bunch of epidemiologists. They're just a bunch of docs chatting and said, I got this old guy who got pneumonia. We can't figure out what it is. And somebody else said, funny, you had a guy with bad pneumonia. I had 2. And they realized after a while that they actually had something happening, got reported to CDC. And in December of 77, Legionella pneumophila was identified as the cause of Legionnaire's disease, and later, as it turns out, other conditions like Pontiac fever. Now, the interesting thing is, to me at the time, is this wasn't in my brand new Harrison's textbook of medicine, neither the original outbreak nor the cause. That wasn't there. And this is just one of many, quote, new infectious illnesses. It wasn't new, it was just newly recognized that could be identified by observant physicians, not by epidemiologists. And the take home is there's new stuff all around. You just have to go looking for it. And next I'm going to talk about Clostridium difficile colitis, something we all know about. This was originally not Clostridium difficile, it was pseudomembranous colitis. And that was thought to be maybe an ischemic process, maybe it was infectious due to Staph aureus, which is actually why it was treated with vancomycin before they even knew what it was. And then in 1978, Clostridium difficile was identified as the cause of pseudomembranous colitis. Came out in the British journal Lancet. And I had to correct the professor teaching the class who had not read the article in the Lancet the week before his lecture. So that probably is not surprising to some of you. And the take-home message there is not everything you're taught is true. We're frankly being taught wrong things. It was the best anyone knew until that article came out and showed that we were wrong. And this is just, the first of many wrong things. Then we had a little condition that we know of as AIDS. And this had just been recognized just before I started my internship. So June of 81, 5 cases of pneumocystis carinii pneumonia, now called PJP instead of PCP, came out. Nobody knew why these previously healthy people had this illness that previously had been seen only in people with pretty much wiped out immune systems. So I started my internship in July. A few months later, in December, New England Journal article came out associating pneumocystis and mucosal candidiasis in previously healthy homosexual men, and they called it a new acquired cellular immunodeficiency. The next year, the term AIDS was coined. And at that time, there were projections that every ICU bed in the US would be filled with an AIDS patient. It was growing exponentially. Average lifespan was 9 months. These poor people died of pneumocystis, Kaposi sarcoma, CMV, lymphoma. The list went on. It was terrible. Now, HIV was not identified for another 2 years. That came out in 1983 and 1984. And you need to think about how much stuff has progressed. It took 2 years to identify the virus causing AIDS. It took 2 weeks to identify and sequence the virus that caused COVID, SARS-CoV-2. That's how much medicine progressed from taking 2 years to even identify to now taking 2 weeks to identify and fully sequence. First drug for AIDS came out in '87. We had HAART in 1996. And now if you are compliant with your therapy, there's an excellent chance that you have more or less a normal life expectancy as an HIV-infected individual. And that's just incredibly transformational over the last few decades. The take home here is don't believe predictions, especially those about the future. The idea that every ICU bed would be filled with an AIDS patient, of course, never came to be. And now, 40 years later, we have the occasional AIDS patient in the ICU, and certainly not all of them. And kind of a fun fact, there was a diet pill called AIDS in the 1980s. Sales did not do well after HIV came out, and they went out of business. We're going to shift gears and talk about some heart things that have happened over this time. And we're going to talk about aortic stenosis. The very first patient I ever saw at Baylor had severe aortic stenosis. This was Introduction to Medicine course, 1977. I did an 8-page handwritten history and physical. I realized to my horror that I had not asked him about his dentures. I went back to Methodist Hospital one evening, knocked on his door, and got a full dental history to put into my H&P. That's how picky they were at that time about what was properly part of a history and physical as a student. He went to surgery the next week and died on the operating table of what's called stone heart, basically inadequate cardioplegia, and he died. That's my introduction to medicine. Your first patient died. In 1977, aortic valve replacement had a 6 to 9% mortality. Okay, I mean, that's incredible. And these were relatively young, single organ system patients. They didn't take people with chronic kidney disease and bad emphysema. These were people in their 50s and 60s who just had aortic stenosis and still had 6 to 9% mortality, average length of stay 10 to 14 days. And now at Seton, we do TAVRs. And for those of you who aren't familiar with that, basically you have the patient's bad calcified aortic valve. You put a balloon in it, crack it open, and then stick a new valve transcutaneously into that spot. And the patient usually goes home the next day with a Band-Aid on his groin with a mortality rate of 0.6%. And this is a group of older people in their mid-70s on average with often multiple comorbidities, including COPD and liver disease and other things. And this is truly amazing. And one thing about this is that it's the most ridiculous idea around. The idea that you would, I mean, if you had taken if you were a cardiology surgical fellow back in 1977 and said, I have this idea that we can crack open the aortic valve from the inside and just stick a new valve in there instead of taking the old one out and replacing it with a pristine, you've been laughed out of the room. So take-home message here is just because something sounds crazy and impossible doesn't mean that it may not work. And, we have a long history of laughing at things that work. The 1860s, washing your hands was laughed at. Well, now, of course, we don't laugh so much about that. Moving on, myocardial infarction has had enormous changes. When I started my training, it was only actually a few years before, 1973, that true consensus had been obtained about whether coronary occlusion was the cause of or secondary to myocardial infarction. I mean, there actually was a serious debate. They thought perhaps the heart muscle died, and of course, because the muscle was dead, you didn't have blood flow, and then it thrombosed. And that was actually the original thought as to what was going on, and it took a significant amount of time to get to the point of recognizing the idea that you're walking around pretty well and you have plaque rupture, and now you have arterial occlusion, and now you start having a myocardial infarction. That was not appreciated. There's hardly an easier patient to admit to the ICU. You couldn't do anything for these poor people. You had bed rest, nitroglycerin, lidocaine. We gave lidocaine because there were so many arrhythmias at that time, because you had myocardial infarctions that weren't being treated. We simply watched them evolve, and a lot of them had developed VF, ventricular fibrillation. So we had them on lidocaine. We gave morphine for pain. We proudly got multiple EKGs to watch the evolution of the myocardial infarction. And then we sat back and waited for mechanical complications such as ventricular septal rupture and free wall ruptures and papillary muscle ruptures and, of course, advanced cardiogenic shock. Patients were routinely watched in the hospital for 14 days. The first several days was truly strict bed rest. And there's the big debate of the day was whether you did pre-discharge exercise stress test or not, whether you took somebody who just had a heart attack 2 weeks before and subjected them to a submaximal stress test. This was a big deal. There was no role for coronary angiography because you couldn't do anything for them. The first balloon angioplasty for myocardial infarction was until 1980, and the first stenting not until 1987. Flash forward a few decades, we have citywide EMS protocols, code STEMIs, immediate cath and stents. And at this time, if you decide to have a myocardial infarction right now and walk down to the ER with it, there's an excellent chance you're going to leave the hospital with virtually no myocardial damage. Take-home message here is change or move out of the way. It's going to run you over. The changes are so fast. Again, sticking with the heart, which has had a lot of things happen, diastolic dysfunction. This is something we routinely understand right now, but back in the day, heart failure was considered to be either systolic, valvular, or obstructive. There was simply no concept of heart failure with normal systolic function. That didn't make sense. How can you have a failing heart with good systolic function and pumping stuff out? And we in the pulmonary section routinely got calls from cardiology with a patient who looked like they had heart failure. They had peripheral edema, their x-ray looked wet, and they said it's not the heart. And of course, some things don't change. We still get that phone call. But, we didn't know better. It looked like heart failures. So we gave them Lasix and they got better. But we had no idea what we had treated. We did not know what to call it. The heart doctor said it wasn't the heart, yet they got better with Lasix. We just assumed the cardiologists were idiots. But as it turns out, what it was is there was a condition that no one knew about. It was called diastolic heart failure. It meant that the heart basically was stiff and didn't work very well unless it got filled with a whole lot of blood. And when that happened, you started getting symptoms of heart failure. But this wasn't a concept that came out until like the late 80s and early 90s. So it's really hard to recognize something that doesn't fit into a bucket. And just because there isn't a name for something doesn't mean that it's not real and doesn't exist. But that's really hard to recognize. And this was a big deal and a big change over the years. Now, heart failure management in general, back in 1977, we had Lasix, and then we had more Lasix, and we even had more Lasix. We had digoxin and digitoxin, and we had sodium and fluid restriction, and that was it. And then starting in the early 80s and moving on through the present, every couple of years, new drugs and new concepts come out, and we now have large numbers of drugs that we have available to use. And remarkably, just a few weeks ago in the New England Journal again, digitoxin is back, or making a comeback, I should say. It was available in 1977. I may be the last person on this call who has used digitoxin, but now it's been shown to potentially add benefit to guideline-directed medical therapy. And I think the take-home message here is that yesterday's evidence-based management strategy is today's malpractice. Things are moving that quickly that you really need to keep up. Now, cardiorenal syndrome. This is, again, I think kind of fascinating. In 1981, we recognized that sometimes when a patient was diuresed, BUN and creatinine rose, except when it didn't. Then BUN and creatinine fell. And we didn't have a clue why that happened. And as it turns out, there are animal models in the mid-20th century that had shown that elevation of central venous pressure contributed to renal failure. But this had not filtered into clinical bedside understanding. I've tried to figure out why that was, and I can't find that. It just somehow never made it in. Or if it made it in, it vanished. And then we started recognizing later on in the 2000s that venous congestion was actually associated with renal dysfunction, and probably a role for decreased perfusion pressure as well. And now we have statements from the AHA highlighting the pivotal role that CVP and venous congestion play in driving acute kidney injury. So we went from a disease, a condition that was actually known about at the physiological level in the dog lab in the mid-20th century and rediscovered in the 21st century. So take home is sometimes the answer is already known. It's just that no one remembers it. And it makes you wonder how many other things out there that we don't know were actually known in the past or known to somebody. We just don't know how to get that information where it belongs. And then supraventricular tachycardia. When I started, we had vagal maneuvers, which means you mash really hard on the patient's carotid artery and hope that that triggers his heart to slow. And we had a variety of medications that were sort of effective. And then we had cardioversion, meaning we could put pads on the patient's chest and apply current and shock the heart into a normal rhythm, something that you see on TV all the time, but we actually try to avoid that when possible. And then in 1982, verapamil was approved. And I remember during its early, we had access to it through a study before 82. And we all gathered in the emergency room at Parkland. We had a young woman there with tachycardia, heart rate of 180, failed vagal maneuvers. And we watched as the cardiology fellows slowly gave verapamil, and then miraculously the patient's heart went into a normal rhythm. And, it's hard to imagine everybody standing around watching this happen for the first time, but it was pretty incredible. Soon after that, the field of electrophysiology was born, and ablations for arrhythmias started occurring. In 1989, another wonder drug came out, adenosine. And again, we would watch it being given, and the patient's heart would slow to sometimes nothing. Everybody would panic. Then it came back working perfectly, and it was a true wonder drug. And there's Weingarten's rule of adenosine, which is the average heart rate in the room stays the same, which I think continues to this day. Well, the take-home message here is that things that you take for granted were once new and amazing. I mean, nobody today views these drugs as anything other than just drugs we've got available. But you have to remember, there was a time when those drugs weren't available. Now, the next thing I have, unfortunately, let's see, yeah, you can see the picture there. So there's a box there, and that box is hooked up to 4 blood pressure cuffs, and it has this kind of crude, dial in the middle gauge thing. And this is something called rotating tourniquets. And what rotating tourniquets refer to is you could put one of these blood pressure cuffs on each limb, one on each arm, one on each leg, and then push the button, and it would inflate these in sequence. And the purpose of this was to decrease venous return to the heart while still allowing blood flow into one limb at a time, and would rotate around. And this was an early treatment to buy you time for pulmonary edema. Okay, and we had this at Seton. And I think I'm the last doctor to ever use it. I used it my first night on call at Seton in the old CCU, which is now ICU-B. We had a patient we were desperately trying to manage without intubating. And one of the things I did to buy a little time was put rotating tourniquets on. Fortunately, never did that again. Okay, we're going to move on to some ICU stuff. Since I'm an ICU doctor, not time to get rid of the heart and move on. And when I started, we did not have pulse oximetry. That wasn't invented until 1983. And I tell this to my fellows, and they have trouble getting their head around it. And quite honestly, I do too. I don't really know how we managed without it. That's how we did. And it wasn't because we were amazing. It's just you don't miss what you don't have. Okay, so, before the home computer was invented, nobody missed having a home computer. Before the cell phone, nobody missed having a cell phone because it didn't exist yet. There were other ways you communicated. There were other ways you did things. And we did not miss having pulse oximetry. Now, you take away our pulse oximeters today, we would not know how to function any more than you would know how to function without your cell phone. But we did. We had single lumen central lines. The Solinger technique did not become available until the late 70s and took a while before they made it into kits. We actually had a catheter through needle system where you had this huge needle that went in, and then the single lumen catheter went through that. Multi-lumen lines did not become available until the 1980s. Patients were commonly flat in bed instead of head of the bed up. We use high tidal volumes in the range of 12 to 15 mLs per kilogram. Now we use 6 to 8 and less. So at every breath, we were literally breaking the lungs apart at a microscopic level, but we did not know that. But that's what we did. Drugs were given by bolus predominantly. There were very few continuously infused drugs. There were very few pumps to use. We counted drops in a drip chamber. There were some piston-powered syringe pumps, but uncommon. IV bottles were made of glass. Almost all ARDS patients had a pulmonary artery catheter, and you say why? And the answer is part of the definition. You couldn't diagnose ARDS, or we thought properly manage it without a PA catheter. Central lines were changed every 3 days. You ask why, and the answer is simple, because that's what we did. And the take home here is, I think the more you know about history, the more scared you should be, and recognize, hopefully, that people in 30 years will be looking back at what you're doing today and hopefully laugh and shake their heads at the ridiculous things we're all doing now, because that's certainly what would have happened back then. This is something that would have been unthinkable. This is actually a fairly not that sick patient in the ICU. And this is the Christmas tree of pumps and drips and stuff. And I mean, he's sick, but not certainly the worst person. But in the old days, we thought that nobody could survive 2 pumps or more. This would have been ridiculous to think anybody could be so sick as to need all this and have any chance of survival. Yet you walk through our ICU, you'll find several people with this at any given time. Now shift gears to nutrition. Originally, intravenous nutrition was called hyperalimentation. This is a term from the 60s and 70s. And we gave up to 60 calories or kilocalories per kilogram per day. 80 kilogram man, that's approaching 5,000 calories. Now, it wasn't a stupid idea. the concept was these are highly catabolic patients with big nutritional deficits. And obviously, you're not going to get better from your serious illness if you're starving. So you got to provide adequate nutrition. You got to treat, replace what they're losing and then try to build them back up. So they got huge amounts of calories. The only problem was that actually didn't work. They developed hyperglycemia, sepsis, fatty livers. Carbon dioxide production was crazy high. They couldn't get off the ventilator. People died. Well, a little later, we came up with TPN, total parenteral nutrition. And that's the term introduced in the late 70s, early 80s. Although initially, we were still using the caloric goals of hyperalimentation. We're still giving large amounts. And gradually, it came down to 30 to 35 kilocalories per day. And then later, parenteral nutrition, get rid of the T. It's not longer total, it's just parenteral. And that's started off late 1990s, early 2000s. And now we're down to, 12 to 25 kilocalories per kilogram per day. And, usually less than 20. And the take home here is the fact that something makes sense. And trust me, hyperalimentation made sense. The fact that it makes sense does not make it right. You need to demand data. You can't base treatment on doing something because it makes sense. A lot of things that make sense don't work. And on that vein, we talk about transfusion thresholds. 1977, we transfused people when their hemoglobin was 10 or hematocrit was 30. It was standard. There's zero data to support it. It just made sense physiologically. If God had made us, wanted us to have a low hemoglobin, we'd have had a low hemoglobin all the time. If the idea that you could watch somebody critically sick in the ICU with a low hemoglobin didn't make any sense. You need blood. You need to have oxygen delivery. I mean, it's obviously correct. Until 1999, when the New England Journal published a good randomized study looking at that, and it found out that transfused blood is so god awful that it's better to be severely anemic than transfused. So we, for decades, watched people go down to hemoglobins of 7 before we give blood if they're hemodynamically stable. That would have been unthinkable. I mean, you would have. It would have been gross malpractice in 1977 to sit around and watch somebody with a hemoglobin of 7. But now we do that routinely, unless, of course, you're having myocardial infarction when new recommendations are back to hemoglobin over 10. So once again, the fact that something makes sense does not make it so. You really need to demand data. And too often in medicine, we've treated people without good evidence supporting what we're doing. Okay, move on. Respiratory failure from COPD. In 1977, severe respiratory failure from COPD was actually pretty easy. Gave ammonophlin, a drug probably most of the people in the audience have never used. We had metoprolol, which was available to us before albuterol. We probably gave steroids. We probably gave antibiotics. And if you didn't get better, we intubated you or you died. It was a pretty easy decision tree. And in 1995, truly a landmark paper came out showing that non-invasive ventilation for COPD worked. And what that means is you simply, instead of hooking up the ventilator to the patient with an endotracheal tube in, you hooked up the ventilator to the patient with a mask. Simply a mask over their face that you hooked up, and then you could take off and on as you wanted. And with that simple change, mortality fell from 26% to 9%. Intubation rates from 74 to 26%. And now it's the uncommon COPD patient who actually dies. So this was take-home message here. Sometimes really simple things can make a huge difference. This is not a TAVR with the incredible infrastructure necessary to make that work. This is a mask that we would use for an ambu bag connected to a ventilator. Now we have a whole variety of comfortable masks. We have non-invasive ventilators that are designed specifically for this purpose. But the key thing here was simply recognizing that using a mask instead of an endotracheal tube might work. It was tested. And, there are very few papers that come out in medicine that show one change can reduce mortality to a third of what it had been. We started doing this, I think, the next day or the day after we had our first patient that we did this on. Okay, pulmonary embolism. Back in the day, how do you diagnose it? Well, we had the VQ scan, which was a pretty garbagey test. We had pulmonary angiography, which was invasive. And of course, we had autopsy, which is a little late. You could look for DVT since the treatment's largely the same. And we had this really crude test called lower extremity impedance plethysmography, which looked at the change in impedance in the legs as you blew up blood pressure cuffs as a clue to whether or not there was venous outflow obstruction. I mean, it's truly ridiculous. That was actually in place until the mid to late 70s. And we had ultrasound for DVT, which really wasn't available until the early 80s. So it was hard to diagnose PE and DVT. And the treatment was IV bolus heparin, not a drip, because you didn't have pumps. We gave 5,000 units every 4 hours. Then we switched patients to warfarin, which is Coumadin, a drug that is a pain to administer, and it took frequent blood monitors and lots of complications. We did have thrombolytics, but we rarely used those. And then in flash forward to 2025, we have ultrasound for DVT. We use CT angiography, so it's virtually non-invasive. We do risk stratification of biologic markers and imaging, such as echocardiography. We have multiple mechanical interventions available to deal with the clot. And we have low molecular weight heparins that get transitioned to DOACs that do not require monitoring. And we did something that was truly unthinkable. We do something now that was truly unthinkable, and that is we send low-risk patients home. It's like, okay, you've had a pulmonary embolism, take these pills, go home. That was unthinkable before. But one thing we need to keep in mind is show me the data. But there's no question that our mechanical interventions for PE are acutely effective. We're still lacking for many of these interventions because they're progressing so quickly. Long-term data showing that the cost benefit actually makes sense. And as we know, medicine is littered with things that, again, made sense, but don't really work as well as we thought. Okay, moving on to surgery. Cholecystectomy and abdominal surgery in general. In 1977, open cholecystectomy was a bread and butter procedure. Every surgeon got trained on it. They did lots of it. They were good at it. And when they were done with their surgery, you had a very painful right upper quadrant subcostal incision. It only hurt when you breathed, and God forbid you coughed. It had a non-trivial mortality rate, enormous morbidity, hospital length of stay 7 to 10 days. The big debate at the time was NG tube to suction or not. And the first laparoscopic cholecystectomy was done in 1985. And I remember distinctly having a patient at St. David's Hospital that I called the surgeon on. He was in the hospital for a few days, and we finally figured out he had gallbladder disease. I called the surgeon, who was a doctor named Ames Smith, who no longer practices in Austin, and saw the patient. I went by the next day to find my patient, and he wasn't in his room, and he wasn't in the ICU. It's like, what happened? I hope he didn't die. What happened is he went home. Surgeon did the operation with laparoscopically, and instead of keeping him in the hospital for another week and a half, he sent him home the next day. And of course, everybody now takes that for granted, but it was not a for granted thing always. This was truly amazing. And the take home here is we're surrounded by revolutions all the time. Just look around. This was truly revolutionary. Okay, changing to GI. Peptic ulcer disease, and the word peptic means related to pepsin and acid. Okay, so the name of the disease, peptic ulcer, means it's an acid-produced disease. And accordingly, before 1977, when I started, we had Maalox, we also had Maalox, we had the milk diet, sometimes cholinergic, anticholinergics, and for refractory, we had surgery. And medical school, residency. There were numerous papers, lectures, pimp rounds about entrectomy, pyloroplasty, vagotomies, super selective vagotomies, all of that. Cimetidine was approved in 1977, the first H2 blocker. All the stuff, again, aimed at acid. And in 1983, Helicobacter pylori was identified as the cause of most ulcers. And it turned out ulcers were actually an infectious disease. Nobel Prize awarded for this discovery. Between 1967 and 2008, ulcer surgery fell by 93%. So take home here, just because you think you know the cause doesn't mean you know the cause. I mean, everybody knew the cause of ulcers. And as I said, the name even told you the cause. This was peptic ulcer disease, but that just wasn't right. I mean, acid played a role, but fundamentally at the actual causal level, this was an infectious illness. And, you know, it was truly a laughable idea, but completely correct. GI bleeding, another area that has changed a little. We had ice saline, lavage, and we had Maalox again. Maalox was one of our biggest items on the formulary. And then again, we had Maalox and we had more Maalox. We didn't have, as I said, H2 blockers until after 78. If you had varices, we had vasopressin, which was an old drug. We had sing-stocking Blakemore tubes, which for those of you who don't know about that, this was basically a tube with balloons on it. You shoved down the esophagus, blew up the balloons, so that they would tamponade or press against the ruptured veins and stop the bleeding. And to secure these in place, they were traditionally tied to a football helmet. So you walk through the ICU, you see all these people that were literally had football helmets on their head with these tubes tied to it and various anchors in place to put appropriate stresses to have the balloons press in the right place at the right time. Paper in 1977 showed that upper endoscopy did not improve outcomes. Of course, we did anything we could do through that endoscopy, so it's not surprising. 1981, another study showed that if the bleeding had already stopped, there was no reason to do endoscopy. It didn't change anything either. And then we started getting more stuff we could do. It's sclerotherapy in the 80s, and now we have lots of endoscopic and angiographic interventions, and trials are being done to determine the appropriate timing for those interventions, but we have lots of things we can do. And again, take home is just because you've got a condition that you don't have much you can do for it, doesn't mean that's going to stay that way for long. Imaging, CT scanners, or originally a CAT scan. The A was for axial tomography, but they got rid of that. And first CT, 1973. 1976, 141 scanners in all of the US. 1977, Methodist Hospital in Houston had just bought a pneumoencephalogram chair. And for those of you who don't know what a pneumoencephalogram is, it's a hideous, barbaric procedure that sounds like it comes out of the Middle Ages, where a lumbar puncture is done, some cerebral spinal fluid is removed, and air is now injected into the spinal space. The person is strapped into a chair, which is tipped and turned in various ways so that the air can move into the brain and allow you to see the ventricular system of the brain and do x-rays that way. The patient had a horrible headache, typically threw up, and this was the best way to see what was going on. Well, they just bought this new chair, but then their new CT head scanner arrived and was installed, and it produced god-awful grainy images that took a minute a slice to acquire and produce, and was so much better than what we had before. They never unpacked the pneumoencephalogram chair. At that time, many states, not Texas, had certificates of need to get a CT scanner. You actually had to go and convince a bureaucratic committee that there was a community need before you could buy a CT scanner for your hospital. Now, of course, we use CT imaging for cancer, screen for aneurysms, diagnosis of interstitial lung disease. We do it for angiography, part of trauma evaluations, workup of septic shock. I mean, the list goes on. You can't function without a CT scanner. Take home here is that Texas was and remains a great state. We never had that nonsense. CLIA, Clinical Laboratory Improvement Amendments. Back in the 70s and 80s, if you're a student, intern, resident, we did our own gram stains, our own AFB smears, India ink preps, urinalyses, we spun hematocrits. measured urine and blood ketones and diabetic ketoacidosis, plated our own cultures, put them in candle jars. In the ICU, we ran our own blood gases at Bentham Hospital. And now, of course, with CLIA, the lab does all those things. And now we're 2025, and many of our younger physicians, I think, have only a vague notion of what gram-positive versus gram-negative means and how you actually do a gram stain. Again, I guess at the end of the day, does it really matter? But the take-home message is that your elders walked to and from work uphill both ways, and I want you never to forget that. Okay, what about the patient that no one can figure out? This will continue forever. The 1860s, the mid-20th century, there was something called neurasthenia that was given to many people. 1970s with click murmur syndrome and mitral valve prolapse was thought to play a role. 70s through 80s, there's chronic Epstein-Barr infection, then chronic Lyme disease. We've had chronic fatigue syndrome, fibromyalgia, sick building syndrome, POTS, Asia, systemic exertion intolerance disease, and now we have long COVID. And I don't want to suggest that these are all fake diagnoses. Absolutely, they're not. There are many people that have these as very real conditions. On the other hand, there are many people who don't have these that get put into a bucket. Physicians and patients crave diagnoses, and we do our best to come up with a diagnosis, and there's always a diagnosis out there. That doesn't necessarily mean it's correct. And right now, if you look at the criteria for long COVID, which isn't to say that it may not exist as a real condition, but almost anything that lasts you 3 months or longer that you can't figure out can be called long COVID. Since everybody's had COVID at some point, and you don't even have to be symptomatic to meet the criteria, anything is long COVID. And that's, I think, should make us all skeptical when you have a name for something that includes everything. Okay, couple fun things. Smoking. Back in 1977, smoking was allowed in hospitals. Many physicians and nurses smoked at work, sometimes in patient care areas. It wasn't until 1992 that JCAHO mandated that accredited hospitals ban smoking. In 1977, the head of pulmonary at Baylor chain smoked, as did the two leading oncologists at Methodist Hospital. In 1982, we had to evacuate the top floor at Parkland when a patient caught his bed on fire smoking in bed. So take home is, yeah, there's stuff you can't make up. You just can't make this stuff up. It really happened. Okay, reaching the doctor. We had overhead pages. You call the operator who would send out a page overhead, and we had fun with that. The page operator would say things like, Dr. Rubin, Dr. Billy Rubin, call the ICU, or Dr. Sigmund Colon, please call X-ray. It got old quickly, but that was pretty standard in July anyway. We had pagers that simply beeped, and then you had to call the operator to find out who was calling you. We had pages that gave you a number to call, and that was it. You didn't know who was calling, but you had a number. Then we had pages that let you text a number and receive a pre-formatted reply like, thank you. That was huge. You could bypass the operator. Then we got bulky cell phones that were too large to carry. Then we had the BlackBerry, huge advance. And I think the last person in Austin to use a BlackBerry was Dr. Morrison. He may still have one, I'm not sure. Then the iPhone revolution came out. And now we're to the point that everyone can call you anytime. I talked to Dr. Sigerfus the other day. The night APP at Seton averages 190 calls per shift. Okay, there are now so many calls that it's literally impossible to provide care or eat without ignoring them in some fields. I've sat down at lunch and watched a hospitalist get so many calls the only way to finish her meal was to ignore the calls. So the take home here is there's a trade-off between physician access and physician privacy and sanity. I don't think anybody's defending the boundary. I think we've gone a little bit too far where anytime a nurse has a question, he or she can bother the doctor, no matter what that person is doing. Medical information, staying up to date. Back then, if you're lucky, your book was only 2 to 3 years out of date. We had journals and something called Index Medicus, which was a listing of everything that came out in either that month or that year. And you'd go to the library and look under pneumonia, and then look under the subheading staph pneumonia. And then you would see that there's a paper that came out in some journal, and then you go back to the stacks and find that journal. That's how medical information worked. You had national meetings that were very important. You had grand rounds that had large turnouts every week at both BRAC and at Seton. We had specialty conferences that were well attended citywide. Up to Date came out in 1992, huge advance, only available on CD. Then we had Zoom meetings, especially in the COVID era. You could go attend the meeting in your office, you could be driving, you could be in your kitchen, raising the question, do you really need to go to Chicago for that meeting? Then, of course, we have the EMR. What do you need to know? Just click the protocol, right? And then, of course, now we got large language model, AIs, open evidence. I'm not sure Update's going to live through this. And again, what do you really have to know? Just wait for AI to tell you the answer. So, the take home here is something as basic as unchanging as learning from books, has gone out. We just don't do that hardly anymore compared to what we used to. Yet that was at one point almost the only way. And I think it's been pretty revolutionary. The physician note has changed. 1977, it was entirely patient care and medical legal documentation. We documented what was needed to show our thoughts and provide information from the next physician who was seeing the patient. We had SOAP notes, H&Ps, consults that all had past medical history, social history, family history review systems, and billing was not based on note elements. Then in 1995, billing became determined by the number of elements in various parts of the note, regardless of relevance or necessity. And this led directly to the rise of the useless review of systems and the nonsense physical exam. 2023, there was a little bit of return to sanity with complexity being part of billing. I think the take home here is that organized medicine has totally failed everybody. AMA was responsible for this abomination, and people did not appropriately push back. Charting, we had paper everywhere. We did not have computers anywhere. In the 1990s, we had one computer per hall mounted on the wall, read-only format, and paper actually worked pretty well. Now, of course, EMR, EHR, was this really revolutionary? I truly think really wasn't that revolutionary. I'm not saying for a moment I ever want to go back to paper, but was it revolutionary? Okay, you can access from home sometimes when your password works. You have pop-ups that theoretically help, but mostly are ignored. It is highly legible. That's great. Anybody ever tried reading my handwriting knows how revolutionary I guess EMR was. They can read me now. We have protocols. We had those on paper also. And now we have note bloat, cut and paste, templated exams that don't tell you anything. And fundamentally, it's the same data. There's disappointingly little added value. Although, yeah, you can chart the hemoglobin or the white count. And that's occasionally nice. And we have sepsis alerts that we always ignore. So I think, again, the take home is you've been let down by your elders. We should have demanded proper electronic medical records and not been complicit in the introduction of the crap that we have now. We're winding down here. We're getting to work in free time. 1981 through 84, it was Bill Deaton alone. 84 through 87, Mike Shapiro and Bill Deaton every other night, every other weekend. And the concept of free time didn't exist. I don't think if you weren't working, you were sleeping. I joined in 87, every third night, every third weekend. A weekend was Friday morning until Monday night. Covered 3 hospitals, made ICU rounds twice a day, including resident teaching at BRAC. Now we work 12-hour shifts, maybe 15 a month. That's called full time. And I think the take-home message is that young physicians are pansies now. You need to recognize what stuff was like in the old days. Everything cycles. What's old is new again. Steroids for sepsis, shock, ARDS. They have come, they've gone, they're back again. Fluids, we used to use lots, now we use less. Digitoxin, I talked about earlier, went out of favor in the 1970s. Now it's 2025, it's coming back. And every one of these changes have been based on data. So take home is just because something has been shown not to work doesn't mean it doesn't. Just because something has been shown to work doesn't mean it does. Artificial intelligence is almost here. This will be transformational. I say it's almost here because it's just showing up. It's not really integrated, but it's going to know where your patient has been, what he has eaten, what she's been exposed to, the meds he's taken. It'll know heart rate, blood glucose, saturation. It'll know the diagnosis already. It'll tell your patient what's wrong. And it'll be interesting to see what our role actually is. Well, not my role, your role. I'm out of here. Transformation in healthcare. There's a medical school locally that talks about transforming the future of healthcare. This is from their website last year. And I'm going to say that saying that you're transforming medicine doesn't make it so. Transformation happens all the time. Just look around. Everything you know had to be discovered at some point. Everything at some point in the past, it wasn't known. Everything you see now will be replaced by something else. Everything you do now will be done was done in a different way previously, will be done in a different way in the future. Everything you know now will be wrong. And the take home is if you don't see changes occurring, you're just not paying attention. Transformation is getting a new heart valve and leaving the hospital the next day, going home the day after major abdominal surgery with a couple of Band-Aids, decreasing ARDS mortality by turning a knob counterclockwise, decreasing heart failure mortality by simply prescribing well-tested drug regimens that were not available before, doing proper studies to see if treatments actually work and abandoning those that don't, treating ulcers with antibiotics instead of surgery, and search engines that give you the world's literature immediately and AI that summarizes the findings. I mean, these are truly revolutionary, transforming changes. You know, looking back, every aspect of management of a patient in 2025 would be malpractice if I did it the way I did it in 1977. Nutrition, communication. We used to be told, don't tell grandpa he has cancer. Of course, we have HIPAA now. We did bed rest for many illnesses that, you know, it was routine part of medical admission for a medical patient was bed rest. Only after they got better did you dare let them out of bed. DVT prophylaxis was absent, which is great in the setting of bed rest. Laboratory diagnoses that weren't imagined, such as PCR, where you can diagnose in hours conditions that used to be, days. Incredible imaging advances. I just touched on the CT scanner, but there's lots of others. Almost all surgical and endoscopic interventions are different, and only a handful of medications are the same. And final thoughts, you know, if you look superficially at hospitals, 1977 and 2025, they look about the same. You had patients in beds, there's often a semi-private room, maybe an occasional open ward. ICU patients had monitors, they had ventilators, IV poles, nurses, respiratory therapists. At teaching hospitals, you get rounds led by somebody with a long white coat and minions with shorter ones following. There were fewer female physicians, but already that was changing. We had more or less the same team of people, but not APPs. We had paper chart instead of computer. But if you looked a little deeper, really nothing is the same now, except I think, you know, we still have caring, compassionate clinicians doing their best. That really hasn't changed. And I think that's all I got. I do have one more thing. There we go. This one is here. I really can't leave a talk without talking about birds. Everybody knows I'm a birder. In 1977, this was my concept of birds, maybe a Thanksgiving turkey. And next slide. Now I am a serious birder. I travel, and this is a southern emerald toucanet picture I took in Colombia. So that's my transformation over 48 years, is gone from Thanksgiving turkey to toucanets. Okay, so that's all I got. This has gone a long time, and if anybody has any questions, I'm happy to, or comments, I'm happy to listen or add my own. And we've got the chat, and people can also raise a hand and talk. Bill, are you still on the line? You have anything to add?
Jordan, this is Shai. I just wanted to say thank you for an amazing talk with perspectives that most of us would never get without people like you and Dr. Deaton to share it. So really appreciate you. Thank you so much.
All right. I'll still be around some on academic half days and add increasingly available only to be able to add historical perspectives, since I'll be by the hour out of increasingly out of day-to-day patient care, but the historical perspective won't change. Saad, you had a question or comment?
Can we still go birding with you?
Yeah, absolutely. I'm going to be I'm still giving my beginner bird walk almost every third Sunday, occasional second Sunday, almost every third Sunday. I'm going to be leading bird walks. Yeah, I like that idea, Parker. Thanks. Medicine has changed, and just the shocking. The thing is, you look around, and you just take it for granted, and the advances in general are so slow and incremental, you don't recognize them as they happen. And you look back and realize it. Occasionally there's something that hits you in the face, like the first time a patient has laparoscopic surgery and goes home the next day instead of 10 days later, or has a TAVR and gets a new aortic valve and is home in a day or two instead of dying on the table. But a lot of these advances are incremental, and they work their way into your care so slowly you hardly notice it until one day you look around and it's like, oh my God, everything is different than it used to be. And I know Bill gave a talk about 10 years ago, and he's got a little different timeline. I mean, he started at an era that, by my standards, was 1977 was unbelievably primitive. Yet at that time, that was state-of-the-art medicine in a major teaching medical center. So we always think that we are at the forefront of science and medicine, yet a couple of decades later, you realize, hopefully, how ridiculously primitive what you thought was the forefront really is. Yeah, could make a great podcast episode. Yeah, the problem with podcasts, they take a whole lot of work to do right. But yeah, that would be a fun history of medicine podcast if only they had a lot more time than I have now. All right. Well, that was fun. I enjoyed putting all this together, and we'll be happy to chat about perspectives and where things have been and where I think we might be going as time moves on. All right. Bye, guys.